that so many of you have joined today in spite of all the festivals approaching. Dr. Preeti Shankar, Vice President of FFPAI, and on behalf of the President, Dr. Tushar Shah and Dr. Pragnesh Vacharajani, the Secretary, I welcome you all to one more of the series of Dr. Tushar Shah. And today he is going to talk about nephrology in family practice. Before we move on to the actual subject, we have Dr. Sunita Manglik from GPA Mumbai. She has an announcement to make. So kindly stay tuned for that announcement, which is about the conference. Over to Dr. Sunita Manglik.
Dr. Sunita Manglik is the Secretary of General Practitioners Association, Greater Bombay, just to give her designation.
Yeah. Thank you. Dr. Sunita Manglik is the Secretary of the Greater GPA Mumbai. Greater Mumbai.
Thank you. Thank you. Thank you, Dr. Preeti, Dr. Vibhakar, Dr. Sanjay, Dr. Tushar Shah, and all of you for this opportunity. Dear doctors, 52nd Annual Conference of GPA Greater Bombay is on the 6th and 7th January 2024 at Jamnabai Narsingh Munji School, Juhu, Mumbai. Registration is 1,500 rupees, and this includes the pre-conference on diabetes at Raheja Hospital on the 24th December 2023. Please note, only for the first 100 delegates who register for the conference. Now, the uniqueness of this conference is that it has stalwart speakers, to name a few: Dr. Y.K. Amdekar, Dr. Gopinath Shenoy, Dr. Tushar Shah, Dr. Nikhil Datar on Living Will, Dr. Kiran Shandelia, Dr. Sanjeev Shah, and everybody is a stalwart. Now, one sincere request is to all the members to please send their clinical cases or clinical papers, non-clinical papers, for presentation in the conference. Now, they should send it by the 24th November 2023 so that it is seen by the judges, and if selected, they will have the honor to present it at the annual conference. Thank you very much. Thank you, madam.
Thank you, Dr. Sunita Manglik. Dr. Vibhakar from Mumbai, you want to add something?
No. Let's go ahead with Dr. Tushar Shah's lecture.
Yeah. Okay. So Dr. Tushar Shah doesn't need any introduction. We all know him. He's a leading academician first and clinician, advanced multi-speciality hospitals. He's going to talk on nephrology for family physicians. Over to Dr. Tushar Shah.
Thank you so much, Dr. Preeti, Dr. Vibhakar, and Dr. Sunita. Looking forward to the 6th and 7th of January for the GPA conference of Greater Mumbai. Today's topic is, of course, nephrology for the family physician. And this time I'm doing the presentation in a slightly different style. It's a slightly light presentation, humorous presentation at times. So here goes. Our first topic will be nephrolithiasis. May I have the next slide, please? Next slide, please. Yeah, so this nephrolithiasis will be taught as an Antakshari. I hope you know the game of Antakshari. The Antakshari is a game where the last letter of the first song becomes the first letter of the next song. And here our take-home messages are devised as such that the last word becomes the first word of the next message. This is just to make it a little more interesting and a variation for myself. So next slide, please. The first take-home message is the only injectable NSAID approved for renal colic in the USA is ketorolac. Typical dose 30 milligram intramuscular or intravenous. And why is ketorolac the only NSAID approved? Because US FDA has not approved diclofenac as a drug, nor piroxicam as an injectable. Next slide, please. Diclofenac is our favorite injectable. Diclofenac injection has two forms, as we all know, the aqueous form and the non-aqueous form. We use diclofenac aqueous 75 milligram in 1 ml very commonly, intramuscular, intravenous. One message here is that's often 50 milligrams of diclofenac is enough to control the pain of renal colic. And just because there is 75 milligram in that 1 ml does not mean that we use the full dose. I would request you to use a 2/3 of that 1 ml if possible to give to the patient of renal colic, especially if the patient has a low body weight. We do hear about deaths due to diclofenac injection, and most likely, that is my assumption, that these deaths occur because we give the non-aqueous form of diclofenac as an intravenous injection. Remember, the regular diclofenac, which is available as 75 milligrams in 3 ml, cannot be given intravenous. It's an intramuscular formulation only. So this is the injectable that we give. The third injectable that is available to us amongst NSAIDs is piroxicam. We don't use piroxicam in renal colic. Next slide, please. The last word of this was intravenous. The first word of the next is intravenous. Intravenous or intramuscular options of injectables include tramadol when the NSAIDs are contraindicated, say due to azotemia, and antispasmodics when you can't even give tramadol. Antispasmodics like hyoscine, muscogast, drotaverine, drotin, or dicyclomine, cyclopam. These are the antispasmodics which can be given as injectables, but these are not very effective. From the word effective, next message, please. Effective medical expulsive therapy requires ureteric stones to be not more than 10 millimeters. Now, this is very important. We all know about medical expulsive therapy. This is when we give medicines to cause dilatation of the ureter and expulsion of the stone from the urine without any surgery or intervention. Now, if stones are larger than 10 millimeters, then automatically you should consider ruling out MET and going straight for intervention. However, if you do use medical expulsive therapy in suitable patients, the most suitable drug is tamsulosin. Tamsulosin given in a dose of 0.2 milligram twice a day or 0.4 milligram once a day until the stone is expelled or unexpelled stone creates threats. We'll be talking about the threats later, but first of all, about the medical expulsive therapy. Young male comes to you, 40-year-old, 35-year-old, or comes to you with a right renal colic, and you find a 6 mm, 8 mm stone in the mid or distal ureter, maybe at the junction of the vesico-ureteric area. If you have a stone which is stuck, then you would want to first try medical expulsive therapy if the stone is not more than 10 millimeters. How do you know that the stone is 10 millimeters or less? X-ray KUB and ultrasound both give size estimations of a stone. You don't need a CT scan necessarily in a stone. Ultrasound and X-ray KUB should be enough. Once you can estimate the stone size, which is not very accurate on X-ray or sonography, then you may be able to decide whether you want to give expulsive therapy. Here, between tamsulosin 0.2 BD and 0.4 OD, I choose depending on the blood pressure of the patient. The patients are usually young, their blood pressures may be 110, 70, 120, 80. If the blood pressure is on the lower side, I don't like to give 0.4 at one time. So I will start with 0.2 and give it BD, because as we know, first dose hypotension can occur even with the specific alpha blockers. And how long do you give? There is no duration specified for tamsulosin. Tamsulosin has to be given till the stone is expelled, which may be multiple weeks. So you can wait for many weeks before you decide your tamsulosin is not effective. How long can you wait? Till red flags appear. So let's go to the threats. Next slide, please. Threats or red flags of keeping a stone in situ. What happens if you keep it in situ for a long time? You may get infection, which may be ureteritis, pyelitis, or pyelonephritis. You may get significant or profuse hematuria. You may get anuria. You may get azotemia, and you may get recurrent pain, all of which are indications for intervention. Next slide, please. Intervention. It can be via procedures like ureteroscopic removal if the stone is lower down, especially. Now, new technology allows the ureteroscopes to go right up to the pelvis of the kidney and crush the stone there and remove it from there. There is extracorporeal shock wave lithotripsy, which we all know about. And for very large stones or stones within the kidney, which are very large and cannot be removed per ureter, we have PCNL, percutaneous nephrolithotomy. All these procedures can remove the existing disturbing stone, but they cannot prevent recurrent stone formation. Remember, stone formers can form stones multiple times throughout their lives, and therefore, after your intervention, prevention becomes very necessary. Next slide, please. Prevention of calcium, as you know, there are multiple types of stones. There's calcium oxalate and there is uric acid stones, the two of the commonest forms. And then there are triple phosphate stones, etc. Prevention of calcium oxalate kidney stones, which are the commonest form of stones, involves dietary changes. What are the dietary changes in calcium oxalate stones? We all know about this, but a slight emphasis again. Increase fluid intake. Every patient with recurring stone formers must take 2.5 liters of fluid, and in summer months, probably 1 liter more. They must reduce salt because excess salt, causes calciuria, increased calcium excretion in the urine, causing stone formation. Reducing non-dairy animal protein. Non-vegetarian food, uh, which is non-vegetarian food, increases the chances of calciuria and stone formation. High oxalate foods like spinach, for example, some nuts, for example, high oxalate foods also increase the chances of calcium oxalate. Another thing that we should avoid is supplemental calcium. Oral calcium supplements do not are not usually preferred in patients who have recurring stones, unless they are very severely osteoporotic patients or their food calcium intake is very, very low. And the last and very important is the myth that calcium-rich foods increase stone formation is to be negated. In fact, calcium-rich foods reduce the chances of recurrent stones. So we must encourage calcium-rich food, and this is including dairy, but more important than dairy is even foods like nuts, seeds, foods like ragi, that is nachni, till, all these foods which are vegetarian foods and rich in calcium and increased, especially in patients who can't tolerate oral calcium. For example, many elderly will not tolerate oral calcium. Even in those, they not in the stone formers, but elderly patients who do not tolerate oral calcium, please remember to recommend calcium-rich foods. Now, prevention must be attempted before considering prevention with medicines, that is chemoprophylaxis. So let's go to chemoprophylaxis. Next slide, please. Chemoprophylaxis chiefly involves drugs like thiazides. Now, calcium stones occur due to excretion of calcium in the urine, calciuria. Thiazides are hypocalciuric drugs, meaning they reduce the excretion of calcium in the urine tract. And again, they will not form thiazides. There are several thiazides available, but long-acting thiazides are the one that you choose. So you choose either indapamide or chlorthalidone, and you don't choose hydrochlorothiazide. In which patient do you give this? Ideally, it should be given in patients who have significant calcium excretion in the day, in a 24-hour period. So you have to ideally do urinary 24-hour calcium. Nobody does it. So what is the second option? The second option is to give it to anybody who has recurrent calcium oxalate stones. How do you know the stone is calcium oxalate? Simple. You analyze the stone when the patient passes the stone. Sometimes you assume that it's calcium oxalate if there is family history of stone formation, especially in the males of the family, then it is usually a calcium oxalate stone. And of course, if you do an X-ray KUB, you find a radio-opaque stone, then it rules out a uric acid stone, because uric acid stones are radiolucent on X-ray imaging, and therefore you can presume that it's a calcium oxalate stone. So recurrent calcium oxalate stones can be partially prevented by giving thiazides. The dose of thiazides is higher than the dose given of 25 milligrams of chlorothalidone or a minimum of 50 milligrams of hydrochlorothiazide if you're using that, and you will monitor the serum electrolytes periodically. Another preventive drug is an alkali. Alkalinization of urine with potassium citrate may help prevent both calcium oxalate stones and uric acid stones. So if, for example, you can't give thiazides to a patient because of, say, age or because of side effects, then you may consider giving such patients syrups like Portrate MB6, potassium citrate syrups, which can be given on a regular basis to prevent stones. The popular syrup, Cetal, is basically a sodium containing syrup, disodium citrate. Even though it alkalinizes urine, it has a sodium component, and this is not something that you want to give to a stone former. So if you have to give a syrup, forget the popular Cetal syrup and give the potassium citrate syrup for alkalinization of urine. Next slide, please. Okay, so that was nephrolithiasis. We'll do more of nephrolithiasis through questions and answers, if any. Let's go to the second topic, which is very common and the area of the family physician or the general practitioner. Let us take next slide, please. Numbers less than 20 grams, 20 to 40 grams, and more than 40 grams. What is this? These are the ultrasound measured weights of the prostate gland. Normal prostate is less than 20 grams. Between 20 and 40 is called a medium sized or a moderately enlarged prostate, and more than 40 grams is called a significantly enlarged prostate. This is a classification which is not clinically very relevant, because sometimes you will get a 30-gram prostate with significant obstructive symptoms, and sometimes you will get a 70-gram prostate without any obstructive symptoms. So what is the second parameter that is useful that tells us whether the obstruction is significant? Next slide, please. The second parameter is this: 0 to 5 millimeters, 6 to 10 millimeters, and more than 10 millimeters. This is the degree of protrusion of the median lobe into the intravesical portion of the prostate, meaning intravesical protrusion of the prostate. As you know, the prostate is at the neck of the urinary bladder, and sometimes the median lobe protrudes into the prostate, causing a greater obstruction of the urethra. This can be measured in millimeters, and if it is more than 10 millimeters, even if the size of prostate is, say, 30 grams, this becomes a significant indication for intervention in terms of medicines, especially. Next slide, please. There is one more parameter to decide whether the prostate size is of concern or not, and that is the post-void residue. As we know, whenever we ask for an ultrasound of the prostate, we ask for USG prostate with post-void residue, or USG KUB with post-void residue. Now, what is a post-void residue? Patient goes with full bladder. You see that the bladder is 400 ml full, and then you, after emptying the bladder, you see the volume again. If the volume is 25% or more, then this is a significant post-void residue. Or if the absolute volume is 250 ml or more and the prostate is enlarged, then this is a prostate which requires significant therapy. So these are the three parameters that you will see: the size, the median lobe intrusion into the urethra, and the PVR. Next slide, please. The other numbers now are related to therapy. there are three alpha blockers, and these are the doses of the three alpha blockers. Alpha blockers are drugs which are symptomatic drugs for prostate. They basically relieve obstructive symptoms of the prostate. They relax the smooth muscles of the urethra, and they also relax the smooth muscle within the prostate gland. So we use tamsulosin, silodosin. I believe that alfuzosin belongs to the garbage bin because it has too many drug interactions related to CYP. So let us.
Sir, sorry to interrupt you, sir. Some people in the audience are not able to hear clearly, so a little louder, sir.
Okay, I will just make this a little closer and
Thank
louder.
you.
Give me 1 minute.
Thank you, sir.
I have some basically a speaker. I'll try that speaker first and see whether that works. Okay. I have switched off my conditioner and I have gone into a new space, and let's see whether that works, because I don't think my speaker will work. Okay, Dr. Preeti, first of all,
Yeah,
you have to tell me whether you can listen to me better.
Yeah, we
do you
can
think?
listen to you. Even earlier, we were able to listen, but someone on YouTube commented.
Okay, I'll be louder so that the
Yes,
YouTube
sir.
people may
Yes,
get
sir.
it better. And meanwhile, we can request Encelad to try to see whether the volume can be fixed from their end. Okay, so I would like YouTubers to please comment on the channel whether they can hear better now or not. Now we are going to alpha blockers. Alpha blockers are drugs which reduce obstruction. The commonest ones we use are tamsulosin and silodosin. Alfuzosin, because of its drug interactions, I request everybody to not use. Tamsulosin doses are 0.2 and 0.4. Silodosin are 4 and 8 milligrams. We know there are two principal side effects of alpha blockers. Alpha blockers cause first dose hypotension, or they can also cause postural hypotension later on. And the other the side effect of alpha blockers is retrograde ejaculation. We have to keep a note of these two side effects on every follow-up. On every follow-up in patients on alpha blockers, even if they are prostate-specific alpha blockers, we have to check the BP in standing position also. Also, we should ask the patient, because the patient may not come out with this symptom. We should ask the patient whether they have retrograde ejaculation, which they will say is that they have an empty ejaculate. They don't expel semen during intercourse. So this can be a disturbing symptom for patients. So one important thing to know is that tamsulosin causes more postural hypotension than retrograde ejaculation, and silodosin causes more retrograde ejaculation than postural hypotension. But both side effects can occur with both the drugs. How long do you give in a BPH patient tamsulosin, silodosin? Lifelong. Yes, that is because it's a symptomatic drug. Unless the prostate is operated for some reason, you will give this drug lifelong. Next slide, please. Alpha reductase inhibitor. These are drugs that are anti-testosterone drugs, meaning they reduce the size of the prostate by not allowing some metabolite of testosterone to act on the prostate gland. The two important drugs here are dutasteride and finasteride. Dutasteride is available as 0.5 milligram and finasteride as 5 milligram. Mostly these drugs are used in combination with the alpha blockers. So you have many combinations, as you know, available. Unfortunately, we do not have a combination of low dose alpha blocker with dutasteride finasteride. For example, you will not get 0.2 tamsulosin with 5 milligram finasteride. So Veltam F, Urimax F, etc., all have 0.4 milligram tamsulosin. That's why when I begin treatment, I start these two drugs separately, meaning I'll give tamsulosin 0.2 OD. Once the patient tolerates, I'll make it 0.4. Then if the patient tolerates, I will give a combination. Till then, I might give separate drugs rather than together. Next slide, please. The other drug, which is a relatively newer addition to the armamentarium of prostate therapy, is tadalafil. Tadalafil, as you know, is a phosphodiesterase 5 inhibitor. It's chiefly used in erectile dysfunction, and it has been repurposed for symptomatic relief to replace alpha blockers when needed. Sometimes alpha blockers are not tolerated because of postural hypotension or because of retrograde ejaculation, or sometimes the patient has both BPH symptoms and erectile dysfunction. Especially for this group of patients, tadalafil is a boon. You can give tadalafil instead of, you can't give both alpha blockers and tadalafil together. I would not do that, but you can give tadalafil to such patients instead of alpha blockers. Tadalafil can be combined with finasteride and dutasteride, and you have the dose is 5 milligram every day taken indefinitely. If you have to give tadalafil to a patient also taking alpha blockers, maybe for erectile dysfunction you're giving tadalafil, then you will have to separate the two by about 4 hours, meaning tadalafil and tamsulosin should be given 4 hours apart from each other. Next slide, please. With 5-alpha reductase inhibitors like finasteride and dutasteride, what happens to the prostate gland? The reduction in size is 20% in 6 months or up to 12 months. Also, sometimes you see a reduction, but the total reduction usually limits to 20%. What does that mean? If you have a patient who has come with a 40-gram prostate to you, then the prostate will become 32 grams, which is not normal yet. So you will rarely be able to normalize the prostate size with these drugs. Therefore, these drugs there are only partially effective, and therefore many patients will land up with surgery. Next slide, please. More than one. This number is important. Very important that if there are episodes of acute urinary retention, more than one episode is enough as an indication for intervention. We call them untriggered episodes of AUR. What is the meaning of untriggered? Sometimes acute urinary retention is triggered by drugs like anticholinergic drugs, amitriptyline, for example. Sometimes acute urinary retention is triggered by infections, prostatitis, cystitis, etc. We should not count these as indications. But suppose a patient has an untriggered acute urinary retention. Patient comes to you, you detect that the AUR is due to BPH, prostate. You will put in a catheter. You will keep the catheter inside for several weeks. After using the catheter for several weeks and starting therapy with alpha blockers and 5-alpha reductase inhibitors, after 4 or 6 weeks, when you remove the catheter, which is called a catheter removal trial, if the patient goes back into acute urinary retention, now is the indication for a surgeon, a urosurgeon, to intervene. This is acute urinary retention as the principal indication for surgery. Other indications for surgery are recurrent urinary tract infection, recurrent gross hematuria, and obstructive uropathy, meaning hydronephrosis and rising creatinine due to the prostate obstruction. Next slide, please. Okay, so that was prostate, benign prostatic hypertrophy. We have discussed it in not very great detail, but the practical pointers are given. We will discuss more during the questions. The other topic that is important and extremely extremely common in women especially, is something called OAB, OAB is overactive bladder. And here I am trying to do some rhyming to teach OAB. Next slide, please. So here's the rhyme. First rhyme is without any reason or rhyme. Some older persons have a detrusor that's working overtime. In this line, I've tried to say that first, OAB is commoner in the older persons, usually age 50 or more. And second important thing is that it is idiopathic without any reason or rhyme. Who will get an OAB cannot be predicted. It's an idiopathic disorder. Next line, please. Symptoms are urgency and frequency without SUI or hesitancy. The ultrasound shows nil PVR and a small bladder capacity. Again, multiple facts in this two-liner. Uh, OAB. OAB basically means that detrusor is overactive. Therefore, the patient will have increased frequency of urination. Small bladder capacity will mean that the patient will feel the urge immediately, or as soon as the bladder is full, the detrusor is ready to contract. Urgency and of course frequency. But this urgency is not SUI. It is not stress urinary urgency. These patients do not get uh, leakage of urine, incontinence of urine on sneezing or coughing or straining. It is an urgency which can be controlled by the patient. And there is no hesitancy, there is no obstruction in this. In fact, there is urgency without hesitancy. The patient will not, hesitancy occurs in patients, females with strictures, for example, or in prostate. Here, there is no hesitancy, no dribbling. The urine evacuates very fast and fully. And what does the ultrasound therefore show? It shows nil PVR. There is no post-void residue. In fact, the patient, when they go for the ultrasound, the bladder is often empty. And if it is full at a small bladder capacity when the patient is urging the sonologist to let them go to pass urine, even though sonologist says there is only 150 ml urine in the bladder. Next, please. Anticholinergics and sympathomimetics can relax the detrusor. Kegel exercises in OAB are a useless maneuver. So, what is the treatment here? The treatment is drugs, and the drug used are anticholinergics because they will relax the detrusor, or sympathomimetics, which will relax the detrusor. Many people will give Kegel exercises in overactive bladder. Remember, overactive bladder is not the indication for Kegel exercises. For Kegel, you have to have a stress urinary incontinence, SUI. So, what you have to give is drugs. Next slide, please. Next slide, please. Tolterodine for the young and solifenacin or darifenacin for the elderly are effective anticholinergics, but not side effect free. There are three anticholinergics that we use now. There were older ones also, which we have stopped using simply because of the severe dry mouth that they can cause. The newer anticholinergics are these three: tolterodine, solifenacin, and darifenacin. Why do I say tolterodine for the young and solifenacin for the darifenacin for the elderly? Because solifenacin and darifenacin are relatively specific for the muscarinic receptors of the bladder, and the effect on the muscarinic receptors in the brain is less. Therefore, dizziness or ataxia is commoner with tolterodine than it is with solifenacin and darifenacin. Why are these two not preferred in everybody? Because they are more expensive. Solifenacin, darifenacin are probably twice as costly as the already costly tolterodine. So you can use tolterodine. The famous brand name, for example, is your Rolitan. It's available in 1 milligram, 2 milligram, 4 milligram, and solifenacin, Solitan, darifenacin, Daritan. All these are drugs used for symptomatic relief. Remember, they are symptomatic drugs. They don't cure the detrusor muscle, and therefore they have to be given lifelong if effective. And what are the side effects of these drugs? As we said, of course, there is ataxia and dizziness, but anticholinergic side effects like dry mouth. The commonest side effect is dry mouth, and of course, there can be urinary retention. instead of an overactive detrusor. You can get a urinary retention in these patients. Constipation can occur in these patients. Next slide, please. If dry mouth or constipation is making the patients sick, try mirabegron, a sympathomimetic. Now, some when anticholinergics cannot be given due to side effects, then we can give mirabegron. Mirabegron, relatively newer drug, is a sympathomimetic drug. Remember, sympathomimetic drugs also will relax the detrusor muscle. We have mirabegron typical dose 50 to 100 milligrams per day, which can be used. Some people use sympathomimetic drugs with anticholinergic drugs. I don't know whether there is an approval there. Mirabegron principal side effect, because it is sympathomimetic. Remember, it's like phenylephrine. It causes tachycardia and it causes raised blood pressure. So that is the contraindication to mirabegron, ischemic heart disease or hypertensive patients. Next slide, please. If no pharmacotherapy works, and last resort, inject Botox in the bladder. Botox, as you know, botulinum toxin, relaxes muscles. In fact, it paralyzes muscles. And if you inject Botox into the detrusor muscle, patient will have significant relief for a few months. Now, the trade-off is that because the detrusor is paralyzed, patient now can have residual urine after voiding and makes the patient more prone to infection. Next slide, please. So that was the end of the rhymes. And we go to do's and don'ts in PSA testing. Prostate cancer is another area where the family physician's screening may be useful. And there are several don'ts, not just do's in PSA testing, because PSA is a controversial screening procedure. It is not as clear cut as mammography or pap smear or colonoscopy. It is much less clearer in terms of benefits. So let's go to the next slide, please. First don't, and this is the most important don't in PSA screening. Don't do PSA as a screening test in someone greater than 75 years of age. There is no benefit. Even if you detect cancer by doing a PSA screen in somebody who's 75 plus, there is no mortality or morbidity benefit by detecting prostate cancer at this age. This is somewhat of a paradox. The older you are, the greater is the chance that you have prostate cancer. But the older you are, the lesser is the benefit of detecting prostate cancer. So you must not do a PSA screen above the age of 75. What is the age at which PSA screen should be done? Usually between 65 and 75. And in asymptomatic patients, you can do a PSA screen. Low backache, which is unexplained, and that will give lead you to do a PSA. The reason is that a low backache is the commonest presenting symptom of prostate cancer because of spine metastasis. Typically, PSA screening is done by most complete health checkup schemes or comprehensive schemes. Now, there is controversy of whether this should be done at all or not, because this may lead to very many unnecessary investigations, including biopsy. However, this is done, and you will often have a PSA of more than 4 being the normal. Let us go to the next slide. If PSA is pathologically high and you believe that there is an abnormality there, then don't jump to biopsy. Now it is universally approved or acknowledged that an MRI of the pelvis should be done in a high PSA situation before considering biopsy. This is very important. So why is the MRI done? MRI is extremely sensitive in picking up the lesions within the prostate gland and any pelvic metastasis if there is. So must do, and MRI may tell us the location of the lesion so well that multiple biopsies may become unnecessary. So MRI before biopsy has become the rule. Next slide, please. Of course, as age progresses, the normal also probably increases, but between 4 and 10 is considered a borderline PSA. It's like TSH. When TSH is between 5 and 10, we call it a borderline TSH. In PSA, borderline PSA, you may, instead of doing an MRI, you may ask for two things. One is a free to total PSA ratio, and the other is a digital rectal examination, DRE. What is a free to total PSA ratio? You have to specifically ask for this. When you ask for PSA, typically they will give you the total PSA, which is say less than 4. However, if you ask for a free to total, they will say, okay, the total is 4 and the free PSA is 1 nanogram per ml. Now, the ratio becomes very important in suspecting malignancy. If the free PSA is very, very low, less than 0.11 in ratio to the total PSA, or less than 11% of the total PSA, then you have to think of malignancy. On digital rectal examination, if you find a nodular hard prostate, then you have to suspect malignancy. And now the next step again is an MRI of the pelvis and not a biopsy straight away. So this is what you do in a borderline PSA. There are other parameters for PSA, for example, rate of rise of PSA, what is called PSA velocity, but we'll not go into that because they are practically less useful. Next slide, please. Do remember this fact that 5 alpha reductase inhibitors like finasteride and dutasteride, they reduce PSA levels by about 50% over 6 months. So if you have to compare PSAs before starting and after starting, remember that if a PSA is 4 before starting finasteride and it remains 4 after 6 months of finasteride, then actually the PSA has risen to about 6 or 8 because finasteride has suppressed pregnancy by comparing a pre-finasteride and a post-finasteride PSA. Next slide, please. Do consider all PSAs above 4 milligram per ml in a person below age 75 as abnormal and deserving of further evaluation. So if you do get a PSA more than 4, so this is where the controversy is. On the one hand, we don't know whether doing PSA on a broad scale is a good thing for mortality, morbidity benefit, just like mammography is a great thing, but whether PSA is a good thing. At the same time, if you do happen to have a high PSA, then you must follow it up with a ratio, digital examination, and if either of these are abnormal, with an MRI. Next slide, please. Next slide, please. And PSA. Now we go to the pyelonephritis or urinary tract infection area. This I've covered in slight brief messages, take-home messages. And first of all, take-home messages on pyelonephritis. The classic clinical triad, how does a family physician diagnose pyelonephritis? If a person comes with fever and rigors, with pain in the renal angle, that is posteriorly in the costovertebral angle, or even flank pain, with vomiting. Now, this triad is classic of pyelonephritis. In this monsoon season, where we are getting so many patients of dengue and malaria with rigors, we can miss pyelonephritis by thinking of only those two things. We have to think of pyelonephritis, especially if the patient is a diabetic, an elderly patient, then this becomes a classic triad. In an elderly patient, you may not get all the classic symptoms. Now, uncomplicated pyelonephritis is more common in women of childbearing age group. Nowadays, we are seeing more and more pyelonephritis in the young women, meaning they first start as cystitis, meaning maybe they have gone for a honeymoon, they have gotten a urinary bladder infection, and then gradually, if ignored, some infections ascend into the kidneys and cause pyelonephritis. These will be uncomplicated. Many uncomplicated pyelonephritis in the young woman can be treated at home. And however, most pyelonephritis may require hospital admission. If you have a pyelonephritis with pregnancy, you have to be hospitalized. If you have a pyelonephritis in a diabetic patient, in fact, even if it's a controlled diabetic, you should get hospitalized. Any pyelonephritis with anatomical renal abnormalities, immunocompromised state, you should get hospitalized. Next slide, please. Typically, what the pathogenesis is of an ascending UTI in pyelonephritis, meaning gram-negative fecal flora, especially E. coli, will first go into the urinary bladder, cause cystitis, and then go up into the kidneys. Some people will have cystitis symptoms first, followed by pyelonephritis symptoms. So you must ask every patient who comes with a flank pain, fever, rigors, whether the patient had a few days back suprapubic pain and burning maturation. Remember, pyelonephritis itself may not cause urinary burning. In fact, it will not cause urinary burning. There is no cystitis in many cases of pyelonephritis. Often, cystitis settles down by the time pyelonephritis occurs. So, any patient who comes with past history or recent cystitis and now has fever with rigors, this may be pyelonephritis. The elderly patients are the patients in which we can miss pyelonephritis easily. Any patient who has diffuse abdominal pain, elderly, and altered sensorium, patient is very uncomfortable in bed, cannot explain what is happening to her or him, then you must consider pyelonephritis as a differential diagnosis. Next slide, please. Let's go to cystitis now. What are the options of treatment of uncomplicated cystitis in the non-pregnant female? Why such a long title? Any pregnant female with even lower urinary tract infection is considered a complicated infection. Pregnancy is an area where we are more careful, and these patients usually will undergo ultrasound, will undergo urine culture, and we will be treating them with antibiotics immediately. Remember, uncomplicated cystitis in the non-pregnant, we can treat even with NSAIDs sometimes, and 30 to 40% of patients will respond just to anti-inflammatory drugs given for symptomatic relief. In the pregnant female, we must do a culture, we must do an ultrasound, and we must treat with antibiotics. Now, in a non-pregnant female, we have choices of antibiotics, which are three choices. Cotrimoxazole double strength given twice a day for 3 days, nitrofurantoin 100 milligram twice a day for 5 days, and a single dose of fosfomycin are the three typical drugs given in uncomplicated lower urinary tract infection in the non-pregnant female. In the pregnant female, we can give drugs empirically to begin with. However, culture is a must, and you must give drugs according to the culture report. If the patient is a male, we have been talking about females. If the patient is a male with lower urinary tract infection, remember that a male rarely gets lower urinary tract infection without any anatomic abnormality in the kidney ureter bladder. So if a male comes with UTI, cystitis-like picture, you must rule out kidney stones or other morphologic abnormalities in a male by doing an ultrasound, and you will need a culture in the male. Next slide, please. Okay, so that is the end of the talk. I don't know what the time is. I'll just check. And Dr. Preeti, you can, it's 4:50. So we have a little of time for questions and answers, if you permit.
Yes, sir. So there are some questions on the chat. Should asymptomatic renal calculi be treated?
Asymptomatic renal calculi have to be advised.
Your net is weak, sir.
Dietary modifications, meaning you ask them to decrease their. Sorry, I'll repeat. Asymptomatic stones seen on ultrasound, say 3 mm, 4 mm in the upper calyx, etc. We often see these stones. We only have to give dietary advice in the form of increased fluid intake, decreased salt and animal protein intake, and stop the calcium supplements if the patient is taking any calcium supplements, and increase the oral dietary calcium intake. Uh, these are the typical things that we advise. And look for causes of the stones. High dose vitamin D given to a patient often is the cause of nephrolithiasis. A very uncommon cause is hyperparathyroidism causing hypercalcemia and nephrolithiasis. So you may look for a cause. However, often there is no cause. It is usually a genetic predisposition to get calcium stones in the kidney. So just warn the patient that they have stones. If they get pain, they should report. Otherwise, just keep the fluid intake high. Yes, thank you.
Can portrait be given in cardiac patients? And how long?
Potassium citrate, yeah, potassium citrate. I do not know has how much potassium. So I'll request one of the maybe Kumar is there on the online and he can tell us how much potassium. But I do believe that potassium citrate is safe even in those patients who are taking sartans, for example, and maybe given in cardiac patients. Sodium citrate, that is disodium citrate, which is your cital, I don't think is safe in cardiac patients.
The use of cranberry.
Cranberry juice and D-mannose. These are the two drugs that have been used as supplemental drugs for recurrent UTI. The evidence for them is sketchy at best, and I do not use them, and I do not recommend them. I've been looking at the evidence in various papers, but I don't think we still have a strong evidence for either of them.
So there is someone having a doubt about a patient. Cause of recurrent UTI every month in a 65-year-old male, well-controlled diabetic, without any anatomical abnormality, with normal PSA. Normal PSA, no anatomical abnormality, and well-controlled diabetes, recurrent UTI every month.
Got it. Yeah, so I don't know. Of course, you will have to refer the patient to a urologist for a evaluation for a morphologic abnormality. Sometimes we miss phimosis, for example, as a cause of recurrent UTI. So many patients have anatomical abnormalities that they cannot report, don't report, or we don't pick them up because we just don't check the groin region. So I think somebody should look at it properly.
For post-residual volume, how many times should the patient micturate after each, I mean, after the scan? That's what I think they mean.
Yeah. So there are many patients who cannot avoid in the first go, and the sonologist will tell them to do a second void, and they will report both first void residue and second void residue. And I don't know which residue to consider as clinically important, but I would say I would tend to look at the second void residue as the more accurate information than the first void residue if there is a second void residue.
Sir, do you recommend hydrotherapy in stone?
Oh, I did not say that
IV fluids.
it is very important. Hydrotherapy is the thing of the past. We have, and for 35 years ago, we learn hydrotherapy and consider it a harmful treatment. Why is it harmful? What is hydrotherapy? Just to tell you that hydrotherapy is giving IV fluids, sometimes followed by diuretics like furosemide. That is our hydrotherapy traditional we used to give decades ago. The problem with hydrotherapy is it worsens hydronephrosis on the side of the obstruction. It does nothing to push the stone out. It does not push the stone out because hydrotherapy does not dilate the ureter. It only dilates the pelvic system within the kidney, and hence hydrotherapy has now been officially given up. Thank you, sir.
So which antibiotic in pregnancy with UTI?
So, cotrimoxazole is safe in the first and second trimester, so I think cotrimoxazole can be given. If I'm making a mistake here, please somebody alert me, but that should not be a problem. Nitrofurantoin, I don't think is a problem. Again, phosphomycin, I don't know if there is real evidence of harm or
Phosphomycin can be given.
good.
Cefixime also given.
Again, please correct me.
Yes.
Can be all cephalosporins are safe, but the point is whether we give those drugs in an uncomplicated cystitis I mean, in a routine cystitis, until we get the culture. So once we get the culture, we can switch to cefixime or other drugs that the culture shows specific. Ma'am, can you tell me about Dr. Preeti, whether nitrofurantoin and is safe? Cotrimoxazole, I think, is safe.
Not preferred.
First and second trimester.
Fosfomycin is given because it's a single dose.
Okay.
It is given in pregnancy.
Given. Okay.
Sir, today you have covered more urological part rather than nephrological part, like stone and prostate and. But
overactive bladder and some infection.
Nephrology.
So nephrology after that is basically acute kidney injury and acute renal failure and chronic kidney disease. I did not cover them specifically because both are more domains of the nephrologist than the family physician. So, for example, a family physician is not involved in day-to-day treatment of a CKD patient. A lot about CKD, we need to know a lot. So that might become a nephrology part 2 section. And infections also, I have not covered in detail.
Use of diuretic and electrolyte imbalance with quite often come across. So you take later on.
That is a great idea. That's a good topic because diuretics are used empirically, and we sometimes misuse diuretics, abuse diuretics. So we must learn the indications of giving diuretics, and that can become a topic by itself.
Urologists also recommend, along with tamsulosin, steroids in form of dapsone or dexamethasone. They said that it reduces inflammation.
Yeah. So there is, if you look at RCTs or if you look at evidence-based medicine, you will find that nifedipine, which is another drug used for medical expulsive therapy, and steroids, they don't have significant evidence for their support. So amongst these three groups of drugs, the alpha blockers like tamsulosin, steroids, and nifedipine like drugs, the only one which has great evidence is tamsulosin. So I do believe I would go with evidence more than anything else because steroids can increase the chances of urinary tract infection in an obstructed situation. Yeah. Do we have other questions on the YouTube? I don't know whether I'm not opening my YouTube, but if we have more questions there, please let me know.
No, sir. Nothing as of now. Dr. Vibhakar, Dr. Sunita, would you like to announce? Sir, before that, thank you very much for this unique, I should say, rhymes and numbers, and it was just exciting. It was very nice. Yes. Thank you so much. I know how much efforts would have gone in to prepare it also.
Thank you so much. Thank you so much.
About the conference, Dr. Sunita, again.
Yes, sir. Thank you so much. Thank you so much, Dr. Preeti, for giving me another chance. Dear doctors, the 52nd annual conference of GPA, General Practitioners Association, Greater Bombay, is on the 6th and 7th Jan 2024 at Jamnabai Narsi Mohanji School, Juhu, Mumbai. Registration is just 1,500. This includes the pre-conference CME at Raheja Hospital, Mahim, Mumbai, and this is going to be exclusively on various aspects of diabetes, a half-day seminar. But this will be only for the first 100 delegates who register for the conference. The conference also includes an exclusive gift, which I think nobody should miss. It is a unisex gift, and you will love it. Now, as also always, we have stalwart speakers. To name a few, Dr. Y.K. Amdekar, Dr. Gopinath Shenoy, Dr. Tushar Shah, Dr. Nikhil Datar, Dr. Kiran Shandelia, Dr. Sanjeev Shah, to name a few. Please register through one of us. You can contact the GPA office, and requesting all of you to send your clinical cases, clinical or non-clinical papers, to GPA office by 24th
November, this is a great chance to present in the GPA conference, which this is the only platform which is by the general practitioners, for the general practitioners, and of the general practitioner. You can present your clinical cases and clinical and non-clinical papers to repeat again. Thank you very much. Thank you, Dr. Preeti, Dr. Vibhakar, Dr. Sanjay Shah, and of course, Dr. Tushar Shah has left. Yeah.
Over to Dr. Sanjay Shah for the vote of thanks.
Thank you, Dr. Tushar Bhai, for having a nice talk on urology more, and expect same for nephrology again. Thank you very much, Dr. Preeti ma'am. Thank you very much, Dr. Sunita ma'am, and all those who watch this live webinar on YouTube. And thank you, Analyst Co team, for having a nice presentation. Thank you all.
Thank you all. Thank you, Dr. Vibhakar. May not be able to join for the conference. Let's see.